Hello guys, hello family, hello friends. This is Dr. T and welcome to Clinical Medicine with Dr. T. So guys, in this video I want us to talk about history taking in obstetrics. History taking in obstetrics. This video is going to be very helpful and it's more relevant for the guys who are just starting with their clinicals. I'm talking about, depends what varsity are you going. In some universities you start your clinicals in third year, some in fourth year, some as early as second year you do go to the hospital. So what usually happens is that as you start your clinicals, they will give you a template, a very long and exhaustive template on history taking, but it's not very functional. Like it's not a functional way of taking history. It's very exhaustive, like I said. It's very long. It asks everything and anything from the patient, so it's very detailed. And when you use that template, you'll find that in the hospital they will just label you as if as someone doesn't know how to take history just because of that template. The reason why consultants, seniors, they get irritated when you can't when you follow that template is because that template doesn't teach you or show you how to adapt or how to rearrange the history depending where you're rotating. Like for instance, the way you take history in obstetrics is not the same way you would take history in orthopedics, or it's not the same way, or vice versa even. So it's not the same way you take history in internal medicine. The way you take history in casualty or in OPD, seeing a medical patient, not the same way you take history in an emergency kind of a situation. The way you take history in peds is different from the way you take peds in obstetrics, in internal medicine, family medicine. So history taking, the way and the format that you use depends where are you rotating and what kind of a patient are you seeing, right? Because there are things that are important in internal medicine that you must mention that are not so important in obstetrics, or they're not so important in peds. And now if you've got one way of taking history, you just have got one fixed way, one fixed format of taking history, you are gonna struggle. And you will find that after you have been sent to go and clerk a patient, the consultant will ask you questions, and they will question the way you take history. Sometimes they will even go back and take history themselves because they can't trust your history, because they see that there's no format in it. You don't know the important things in your history, so you need to know what is important depending what kind of patient are you seeing, and depending where you're rotating as a student. Yeah, in some cases you'll find that it happens so many times that you are sent to go sorry, you are sent to go and take history. When you come back to present, they don't even focus on the condition. They don't focus on the condition, they just focus on your history, because they can see that there are so many gaps and you end up not learning about the condition that you're presenting. Now they're just grilling you and hammering you about your history, right? Okay, so we're gonna be talking about how to take a good history in obstetrics, functional history taking, not very exhaustive. Because I mean, if you follow that template, you will never finish your patients. It's so exhaustive, and some of the questions that you ask there, or some of the details that you collect from the patient, are so unnecessary. Okay, let's say now I'm seeing a patient. Say I'm gonna put my date there. In some places, they would ask you to indicate where you're seeing the patient. Let's say you're seeing a patient in, you just write, is it in maternity, labor ward, is it in casualty, is it, where are you seeing the patient? They would want you to write that. Then you write the date. Let's say today is the 12th of June. Let's say I'm seeing this patient at 1800 hours. So the patient that I'm seeing, let's say it's a 30-year-old. sorry. So it's a 30-year-old, right? It's a 30-year-old. Let's say it's graph 3, para 2. Let me put the A there in orange. Let's say alive 2. And some, depending where you are training or where you're doing your internship. In other places they don't put the A. In some places they do. Like for instance in Pretoria, they always put the P and the G and the P. Then that's it. But where I trained, where I did my internship, they always put the A. So it depends where you are. So since I'm working in a hospital that fits to where I did my internship, I still put the A. But if I were to go back to Pretoria, I wouldn't put the A because they don't put the A there. Okay. So this patient has been pregnant 3 times. This is her 3rd pregnancy and has given birth 2 times, and both of her kids are still alive, right? So that's my entry there, my entry notes. And now the next important thing is, if you can check this, I've sort of like completed, I've given a brief overview of this patient's obstetric history already, right? Okay. But and then the next question, the next thing now to talk about is, she's pregnant currently. How many weeks is she pregnant? So say let's say she's 36 weeks. 36 weeks. 36 weeks, 3 days. Let's say that. Now, after writing 36 weeks, 3 days, you have to tell or indicate how did you come to that gestational age. What method did you use? So it can be by dates, it can be by ultrasound, right? And if it's by ultrasound, you need to indicate, is it an early ultrasound, is it a late ultrasound? Where I'm working, you hardly get people do a scan early. It's always late or dates. So if it's an early ultrasound, you'll indicate by, so you're gonna say something like this, early ultrasound. If it's late, it's gonna sound like this, late ultrasound. This is an S, right? When you're presenting these patients, I mean, once you say, I'm presenting a 30-year-old G3P2 A2 at 36 weeks, 3 days, and then you move on to other things, they will bring you back. Even when you are doing examination, when you're in an exam setting, don't leave pockets where they can come into and disrupt your whole presentation. Because the earlier they disrupt you when you are presenting, you're just gonna panic, and then your exam is just gonna take another direction. So just try to minimize, when you're presenting, try to minimize being interrupted because of the things that you didn't mention or things that you didn't or you overlooked. Just make sure that you include everything that is necessary so that you minimize them interrupting you. Because now if you say 30-year-old G3P2A2 at 36 weeks, RVD non-reactive, they'll ask you, how did you come to that 36 weeks? So you need to tell. Okay. The next entry from there is the RVD status of the patient. Very important. The RVD status of the patient, or the HIV status of the patient. So patient here can either be on treatment. If the patient is on treatment, just say RVD reactive. On ART, you can indicate for how many, since when or whatever, or if they've defaulted, you can indicate that there. Let's talk about someone who's RVD negative. RVD negative. If the patient is RVD negative, I mean, this information, you'll find it on that booklet, that maternity booklet. If the patient is RVD negative, you have to write the date there. Say, let's say it was the 1st of March, 2022, right? The reason why you want to know the date is, it's because you want to know if they've had a test recently, or how long have they had the test. Because if it's very long, it's been weeks, it's been months, it means they are due. Remember, when you are asking about the RVD status of the patient, what you have at the back of your mind is PMTCT. PMTCT. This is the reason why. PMTCT. You are thinking about PMTCT. And according to the PMTCT protocol, like if you go and watch my video, I did this, I recorded a video last year where I discussed the protocol. Like in that video, I explained that PMTCT does not start when the woman is pregnant. It actually starts way before they are pregnant. That's when it starts. Because, I mean, we know the best way of preventing mother to child transmission of HIV is having the mom negative. That's why it starts before. And if someone who's taking treatment wants to fall pregnant, they should discuss with their doctor and ask, when is the best time. The best time to become pregnant when you are on treatment is when you are virally suppressed. That's the best time. Imagine falling pregnant when you've got high VL, low CD4s, all those things. If, as much as CD4 is not really used nowadays, it's the VL that is being used. So if they've got a very high VL, the chances of transmitting the virus to the baby, they're very high. That's why what I'm trying to say is the best way of preventing mother to child transmission of HIV is by staying negative, right? HIV negative. Now, if you happen to be on treatment, you need to discuss with your doctor. Doc, when is the right time to become pregnant? What your doctor is supposed to do is supposed to check your VL and say, right now you are very high risk of transmitting. Let's give it another 3 months. Let's give it another 6 months and see. And then we repeat the VL and see, right? Now, throughout the pregnancy, you must be tested. As long as you remain negative, you must be tested every time you come for your ANC. And even during delivery, that's what PMTCT states. So please watch that video. I don't want to talk about PMTCT in this video, but this is what you have in mind when you are inquiring about them. Because remember, in exams, if they want to ask you, because they can ask you anything, if they want you to, if you mention that the patient is RVD negative, then they'll start asking about PMTCT. You must understand what is the goal and how do you actually, practically, how is PMTCT practiced, right? And all of that. And you must know if the baby is born, what drugs are they given? And the drugs, they depend on, because after the baby is born, then the baby needs to be classified whether it's a high risk or a low risk. And you classify the baby as a high risk or a low risk depending on the viral load of the mom. If the viral load is above 1,000, that's a high risk infant. If it's less, that's a low risk. And a high risk receives dual therapy, AZT and nevirapine. And the other one, low risk, which is a mom with a less CD4 count of less than 1,000, the baby receives only NVP. So please go and look at that protocol, PMTCT. I have it on my channel. So that's the reason why you ask about that. The second thing that you ask about is the rhesus status of the mom. They always do it. So you want this to be positive, right? So we are going to talk about what do you do when you've got abnormal RH and all those things, right? um, and then RPR, the RPR status of the mom. So this one can either, you want this one to be negative, right? Because if it's positive, it means the mom. So I think I need to get it to make a different, a separate video for RPR, how to interpret and all of that. But basically, when they are positive, they are given, look at the titer as well. When they are positive, usually they receive 2 doses of penicillin, benzathine penicillin, one so they receive, I think it's 2.4 mega units. Receive 2.4 mega. If it's 1.2, it's 2.4. Just need to check that. Mega units IMI weekly for 2 weeks. So what you're thinking about here is a congenital syphilis by the bacteria Treponema pallidum, right? Okay. So once you, this is, if you can check in obstetrics, be it at the clinic, in the ward, these are the entry notes in all the files. This is the kind of information that you just get as you open the notes. Then from there on, now you will get to the point where you talk about, you ask the patient about their complaints. Why are they in the hospital? Why do they come to you in OPD? Blah, 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 blah. I mean, they can tell you anything depending how they are feeling. They can tell you anything there. They can talk about cough. They can talk about whatever. Then you write that. Then, one question that you must never forget, ask about the fetal movements. So ask them about the fetal movements. Have they reduced? When was the last time they felt the baby moving? Or are they just normal? Blah, 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 things like that. Because sometimes patients will tell you that the last time I felt the baby was 2 days ago. That would prompt you, that would force you to go and do an ultrasound, do the NST, check if the fetal heart activity is there, that kind of a thing. Obviously, if someone is that advanced, you might also want to ask them about labor pains. Even if they did not mention them to you, ask them about the rupture of membranes. Ask them about if they have had any show, history of show, that kind of a thing. And then you come to, so you come to now to your, let's say you get to your gynae history now. You know, gynae history, when a woman is already pregnant, I mean, the issue in obstetrics, the issue of menarche, I don't see its relevance in obstetrics. But if we were talking about a gynae problem, then it would be important. But in obstetrics, I don't see it being important. I don't ever bother about it. Contraception, we can talk about that. Because I mean, people who don't know how far they are in their pregnancy, there are people who fall pregnant immediately after they've stopped their contraception, or they had a break, or they didn't receive a dose, or they didn't take a pill, or whatever. There are always those issues, and those, they actually make it very difficult to actually date a woman and find out actually how advanced are they in their pregnancy, right? So as far as obstetrics, so you can go up to that in terms of gynae. And also if they've got any, they were diagnosed with any gynecological problems, you can mention that, things like your fibroids and all of those. So you can just put those there, diagnosed with fibroids, blah, 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 blah. And then when it comes to your obstetric history now, this is where you can become exhaustive. You say, okay, she was a G1, she got pregnant maybe in 2010. And this information, though, you also have it on the other side. But for the sake of completing the history, 2010, they delivered a female baby. It was a C-section. Then you can write, why was it a C-section? Was it fetal distress? Was it CPD? What was it? Then they had their second baby, maybe, let's say in 2018. It was a male. It was an NVD, or it was a C-section, whatever. And you can just write what problems occurred there, right? And since they've had a C-section, you might want to squeeze in some anesthetic. If they had anesthetic problems, you can just ask them and put it there, right? Just put it there, because you don't even have you don't really have a place where you can write about previous anesthesia exposure. But if there's anything significant, then you can just put it there. Then if it was someone who had miscarriages, you would put that at what gestational age did they have the miscarriage. Was it a first trimester? Was it a second trimester miscarriage? Was it a third trimester miscarriage? Did they have an FSP? Did they have an MSP? You can put those things there now, when, and all of that. Then you come to your past medical history. Very important, especially, and also another thing that you can put, if they've had PIH in the previous pregnancies, put that there. If they were eclamptic, put it there, and all of that. Then come to the past medical history. You can put your HIV again there, positive, and if there's anything that you want to detail, maybe they have changed treatment, maybe they're on second line now, or maybe they defaulted, or they've had reactions to the drugs, that kind of a thing. So you can put that there. And also you can also put the bloods there, like the VL. If you have recent, you can just put, or the latest, you can put it there, or your CD4 count if it's available. If they are hypertensive, they are diabetic, and all of that. And also if they had gestational diabetes, you can also put it there, right? Then you come to your past medical history. You're done with that, and then you can also put your past surgical history, previous operations. So the operations that you're gonna put here, it's not your obstetrics, or you can put your gynae operation if you want there, if they've had a gynae operation, if they've had a gen surg operation, a neuro surg operation. But if it's a C-section, you just put it under obstetrics. You don't put it under gen surg or surgical history generally. Just put it there, right? Then the other things like your if social history, travel history, if they are presenting with a condition that might want you to exhaust that kind of history, then please do. But generally, this is where you would end it in terms of your history. If they've got allergies, you can put it there. If they've got allergies, right? But you don't have to do a travel history for everybody that comes in. You don't have. There are things that you're gonna have to omit, right? We are gonna do history taking, maybe how would you take as you would rather take internal medicine. We're gonna do that as well, maybe sometime next week, and see and compare with this one. How different is it, right? Then after you have covered that, then you go to your examination. You do examination, and you know the forward. And always when you do examination, you describe the patient, how the patient looks, and you put your vital signs. Put your vital signs, right? And as for someone, after doing your examination, remember the abdominal is very crucial. The PV is very crucial. I'm not saying you're going to do a PV exam for everyone that comes in through the door. Depends what are you suspecting, depending on the symptoms the patient is presenting with, right? And now, as for someone who gives you this kind of a history where the PIH, you want that blood pressure, you want BP for all patients, but for these ones, it's very, very important. Someone, and then you need you want a dipstick as well. Check if they've got protein. because if they've had a PIH in their previous pregnancies, they might have it even now, because one of the risk factors of PIH is when you've had a PIH before, right? And then do examination, then you're done. You make an assessment, and if you need to do a scan, you do an ultrasound, and make an assessment and make a management plan depending on the presentation. But basically, this is how you write your history in obstetrics. Most of the times you will find that when you go to the ward, you will find that most doctors, they do this part, they will do this part, then from this part they will jump straight to examination. Not that they don't know that they need to exhaust this, but most of the times you'll find that the issue of let's say now this lady, in their previous pregnancies, she had she's a previous at times too. This information, he won't wait, the doctor won't wait to write that kind of history there. He's gonna put it right there. And there, so when we write, we want to minimize the amount of words that we use. When you write a lot of things, many times it's usually time wasting, and if we could use numbers to write everything, we would just, it's easy to interpret numbers. It's easy to interpret numbers, and it's quicker to write. So we want to shorten what we write as much as possible, but not leaving the crucial information. So don't be surprised when you read 30-year-old G3P2A2 at 30 weeks, 36 weeks by dates, previous times 2, right? Or plus PIH or previous eclampsia. They're just putting everything together that whoever reads can just get the important information, like first hand kind of a thing. So as a student, I don't think there's anyone who will ever fault you for writing like this. Put this there, come to your complaint, come to your gynae history, come to your obstetric history, come to your past medical, past surgical history, just do your allergies, and then do your examination, observation examination, and not forgetting your vital signs. I hope you guys learned something from that. Thank you.